Thank you very much indeed for inviting me and for Rosie for sourcing the programme. Pleasure to be here, and I know I've got 40 minutes, and so I will finish on time. Well, I might anyway. We'll see how it goes. So I'm a psychiatrist. As you've heard, I work at King's College London. I served in the military in the Royal Navy for about 24 years. And I guess my interest in this topic sort of comes from my experience of both working in the military, but also since I've left, working with a whole host of organisations. And I'm really quite fascinated about how organisations can really help their staff have a good state of mental health. When I was in the military, if I went onto a ship and spoke to a captain and said, "Oh, right, we need to help your crew because we need to be nice to them," the captain was a bit interested, to be fair, probably not very much. But if you started to talk about operational efficiency and sort of grades, and he got really excited. So what I've kind of realised over the years is actually, as well as looking about a health and wellness agenda, it's also just as important for how productive a workforce is. And I think you can kind of look at it in both ways. When you look at the topic generally, if you happen to read newspapers like the Daily Mail, and I strongly advise you not to, then the view is this kind of view. It's a pessimistic view that if you go to work, inevitably, you'll end up with stress and probably a mental health problem and probably being mismanaged. But in fact, actually, that's not really the truth. The evidence into is work good for you goes back many hundreds, if not thousands of years to Galen, back in the 129 to 200. And the point being is that we all know that the right workplace absolutely isn't just okay, it's actually psychologically sustaining. And many of us might go to work having had a pretty rubbish home life, and actually work is really what keeps us going. But there's no doubt that probably for a small but really important minority, and one of the studies here by the HSE and DWP shows that roughly 80% of workers say that work's good for you. But that does leave an important minority who say, well, actually, work is not good. And you've probably heard of this concept of the toxic workplace, which I think is a lovely term, which describes all the bad things that could possibly happen, and you put them in one place. And I'm sure you or your colleagues might say, oh, I've worked somewhere like that once in a while. Everyone's got a story. This is an infographic from Public Health England. I'm not going to go through each of the points there. But what this very clearly shows is that as well as work affecting your mental health affects your work. And there is a two-way symbiotic relationship between the two. And it's very hard to say in many cases in this sort of chicken and egg about which came first. Did the mental health problems cause the difficulties, or did the difficulties at work cause the mental health problems? And before, that's obviously from England, but this is just little graphics I've got from around the world. Mental health at work is a really important topic worldwide, not just in the UK. I thought this is an important slide. It comes from the Stevenson Pharma report. I don't know if you've seen that. That's Thriving at Work. It's a relatively recent, year or so ago, report about mental health in the workplace. And what this is basically looking at is the chance of leaving work if you have a mental health problem. So overall here, you can see 3% of people with no mental health problems leave the workforce each year, 4% if you've got a physical health problem, but 6% if you happen to have a mental health problem. So one of the real dangers of having a mental health problem at work, particularly if it's persistent, isn't just it ruins your work at the time, it also ruins your potential to keep going. And once you lose that routine, and once you're away from work, then it becomes much more difficult for your mental health and to get back into the workplace. You've probably heard of the term absenteeism. You've probably experienced it at times. Not sure if you've heard of the word presenteeism. So presenteeism refers to the being at work in body but not really being there in mind. I think this is quite a useful study, so 2012, showing that different reasons that people stay away from work, unfortunately mental health, or depression in this case, comes top of the pops. I'm never very sure whether, as a psychiatrist, I should be happy about that because it means I'll be employed for many years to come, or whether we're not doing enough to try and tackle the problem. And of course, very occasionally, very bad things happen. And so if you are in a safety critical role and your mental health is affected, then actually really bad things can happen. And I've got a few military examples there because I've got a military background, but also the Germanwings plane crash that you will be aware of in 2015, where whatever the real truth of the matter is, unfortunately the pilot was known to have depression and not enough was done. My younger brother is a train driver, which is slightly frightening actually because I travel on trains quite a lot. But the fact is, within train drivers, unfortunately, the chance of them running into someone throughout their career is pretty substantial. And it is a hazardous profession in that sense. I always wonder about the amount of screening or selection that goes into train drivers compared to airline pilots, and I can tell you it's nowhere near as much. But I also wonder, what about coach drivers? Who are driving our children around, and 50 people in a coach. I wonder what selection goes in to become a coach driver. I suspect it's even less than train drivers. And of course, I don't need to tell you about this. There is obviously not just taking other people's lives, there's also the risk that sometimes mental health problems at work also can have an impact, and suicide at work isn't just a tragedy for the individual, it's also often a tragedy for the people around them as well as their families. So in terms of stress at work, there are many different sources of stress. As a military psychiatrist, I was going out to Afghanistan and Iraq, and everyone assumed that most of the mental health problems out there would be because my buddy died in my arms or I saw this terrible scene. In fact, most of the mental health problems out in Iraq and Afghanistan were my spouse doesn't like me, I don't get on with my boss, there's too much work. All the stuff that you will no doubt hear about in your workplaces too. So I think home, work, and trauma, particularly, all interact to create the state of someone's mental health. So what are common mental health problems? What sort of problems do we generally see in the workplace? And here's just a few of them. So anxiety disorders, you'll be aware there's lots of different sorts of anxiety disorders. It's not a diagnosis in itself to be anxious. People get anxious for many, many reasons. Anxiety is sometimes very adaptive, often helps with revising for exams to be a little bit more anxious than not. But you've also be aware that, unfortunately, newspapers like the Daily Mail tend to misuse depression and misuse anxiety terms, and they sort of turn them into sort of common parlance. For instance, have you ever heard of someone saying, oh, I've got a bit of OCD? Well, for any of you who know anyone with OCD can be an incredibly, disabling condition. If you happen to be a bit keen on paying attention to detail, that may be a good thing. It's not the same as having OCD. And for those of you who worked with an anxious person, you'll also be aware that it can be infectious to some degree. I know it's a funny term to use, but actually if you're in the workplace and someone says, oh, have you done that? Have you checked? Are you sure all the time? It can particularly, cause some difficulties. What about depression? Depression isn't just being sad, as you know. It's a persistent disorder that goes on for at least a couple of weeks. And often, not always in men, but quite often in men, they don't present with low mood. They present with being knackered all the time. And actually, when I see someone who's depressed, as I say, particularly in men, what they often talk about is having no energy and just being constantly tired. And then when you start to probe, there's a whole lot of other stuff underneath that surface. And as you'll be aware, depression is a specific risk factor for self-harm and for suicide. What about trauma? I can't give a talk without not mentioning trauma a little bit. I think it's important because this is the definition for what a traumatic event is. It comes from the Diagnostic and Statistical Manual, Volume 5. If you can't sleep, a couple of pages of that just before bedtime is far more effective than sleeping tablets. But you see, the important thing here is trauma is about things that happen, but it's also about things that could have happened. And actually, you can develop a mental health difficulty just because you really, really believe that something bad was about to happen. And I think of relevance for the veterinary profession is this last piece, is that if you're constantly dealing with traumatic situations, patients who unfortunately aren't going to make it and the like, then actually that can have an accumulative effect over time. So when you see trauma in the newspaper, what they often are talking about is a sort of terrorist incident or a big fire. And you can take someone who's functioning reasonably well and then they come to work and they're shouty and they're avoidant and you hopefully can spot those sort of problems. But actually, if you're in a workplace where actually you're constantly dealing with really difficult and potentially traumatic situations, you can go gradually downhill over a while. And actually the thing that actually makes you present as a case for the first time is that someone's moved your chair, or the office meeting didn't go as you expected, and everyone goes, well, that's really strange. Why should they have been so reactive? Why are they overreacting? Well, actually, they've been going downhill for a while now, and no one's really known. Not sure if any of you have heard me speak before, but if you have, you'll be aware that when you ask people how they're doing, the answer is usually, I'm fine. And fine stands for fucked up, insecure, neurotic, and emotional. But actually, it might do, or it might mean I'm okay. And many times, if you speak to people in an organisation, they say, well, how is Sandra? How's Bob? Oh, I asked them, and they said they were fine. That is not a mental health check. So you need to get beyond fine, for sure. In terms of after a singular traumatic event, we know that most people have some symptoms. This is a group of people who were subject to armed robbery, which we can probably agree is a reasonably traumatic event. And what you can see here is straight away, lots of people, 60%, have lots of symptoms. They can't stop thinking about it. They're jumpy, all the rest of it. But most people recover pretty quickly. Now, if you read the Daily Mail will do a lot of reporting over here, and it will say, life will never be the same again. We need lots of trained counsellors to come in and make everyone better. The people we really need to be worried about are these people who have a persistent disorder. Having some symptoms, some reaction to a trauma in the early stages, not sleeping, thinking about it a bit, all that is completely and utterly normal. What you don't need is to turn that normal distress into an illness. What about alcohol and drug misuse? As you'll be aware, the guidance limits are 14 units a week, whether you're a lady or a man. And many of us, put my hand up here myself, might drink more than 14 units a week on occasion. But the question really from a mental health point of view is it impacting on your mental health? Are you developing a harmful use of it, or are you dependent? I don't know if you've seen the CAGE questionnaire before. It's a very simple, easy 4 questions you can ask. Have you felt you should cut down? Have you got angry when people said you should drink less? Have you had guilt about drinking? And have you taken eye-openers? And I hope you don't know what eye-openers mean, but just in case you don't, it's those ones you have in the morning, to help you get going. I won't ask if anyone knows. But if you answer more than 2 out of 4 of those, that's a really good basic screening test for maybe I'm drinking more than I should do. And of course, in the workplace, which is good news, is occasionally we get people who have really quite serious mental health problems. And actually, I think it's a great improvement over the last 20 years, is actually we've seen more and more people with serious mental health problems who actually are still in the workplace. And, there's a whole range of different disorders there. So common mental health problems are common. They certainly affect health and productivity. They're pretty well understood, and it should be pretty easy just to get on and treat them, shouldn't it? If you've got a physical health problem, hopefully you recognise that, you go and get some help, and then you go back to work and you get back to full function. So presumably if you have a mental health problem, again, the same thing goes. You just go and get some treatment, and get back to work, and get back to full function. But you'll be aware there are lots and lots of different barriers that prevent people going to get help. And we'll talk about a few of those in a minute. But it is certainly nowhere near as simple to get help for mental health treatment as it is for physical health problems. And we won't go through all of those particular pieces. And the reality is that mental health treatment is often far more complex than, can I get 12 sessions of cognitive behavioural therapy? Can I get antidepressants? Can I get some sick leave? And I put a bowl of spaghetti up there because I think what often happens is organisations look at saying, right, well, what we'll do is we'll get a staff counsellor, or we'll get Bupa access so people can get their treatment, straight off, all of which is really good news. But actually, if you just provide 12 sessions of cognitive behavioural therapy and you don't address the cause of the problem, then actually you're not really going to solve the situation in the first place. One of the real pleasures about being in the military was that if you had 3 sailors come and see you and say how depressed they were, and they were all working for the same sergeant, actually, it made it very easy to see that the problem wasn't the 3 sailors, it was the sergeant and their management style. And, I was lucky enough to be able to do something about that. It's much more difficult, I know, in a civilian workplace to sometimes tackle difficult management, but that can absolutely cause those problems. You've heard of stigma. Different types of stigma are described. Self-stigma is the views that you hold about yourself. I can't possibly have a problem because if I did, there'd be something wrong with me and I'm not that sort of person. Public stigma are the views that others hold about people with mental health problems. You know, I don't want people like that in my workplace. They're dangerous, they're a waste of space. And discrimination are policies that are put in place, whether intentionally or not, which unfortunately cause people not to be able to come to work. And they all have different characteristics. We've got a long history of stigma in the UK. I've got military examples here, but actually these are very representative of the time of the society at that point. In World War I, if you were frightened and didn't want to fight, we would execute you. It was a pretty strong deterrent, I imagine, but we ended up executing 360 odd people who didn't want to fight in the First World War. In the Second World War, you probably heard of the term lack of moral fibre, LMF. This was an active policy put in place by the Royal Air Force, because in the first early part of the war, if you were flying in Bomber Command, you had a greater than 50% chance of being shot down in your first 6 missions. So it was really dangerous. So guess what? People weren't that keen to fly. But when they said they were scared and didn't want to fly, the senior commander said, well, we can't have this. And so they said, okay, you suffer from LMF, lack of moral fibre. And what that means is we're going to take your flying badges off you, we're going to demote you, you're going to do a walk of shame down the unit with everyone doing this at you, and you'll be cleaning the toilets out. And it was so unpleasant, so stigmatising, that people carried on flying even when the risk of dying was high. Was that the right thing? I'll leave you to make that judgment yourself. But certainly things have changed quite rightly over the years. In the US, if you get injured in combat, you get a medal called a Purple Heart. I don't know if you've ever heard of those. If you suffer a psychological injury, you don't. Now, it's interesting that they didn't set out to discriminate, but over the years, that has become more and more discriminatory. When we look at military personnel who have just come back from deployment, so this group of people, there's over 10,000 in this sample here, of people from the US, the UK, Australia, and Canada. And we asked them, why wouldn't you seek help for a mental health problem? So these are one day out of a combat zone. The 2 biggest reasons are, I worry what other people would think of me, and I worry that my bosses particularly would think that I might treat me differently. I'm worried what would actually happen. So the barriers, the stigma barriers, were really about practical things, about worrying about other people's view, rather than I don't know where to get help and the like. That's all very military. This is data from journalists, and of course journalists are another group of people who routinely get themselves in some difficult situations. They wouldn't seek help again because they wouldn't be given responsibility. I wouldn't be trusted by my peers. I'll be embarrassed about asking for help. Now, when we started doing our military studies years ago, we kind of knew that military personnel had a stiff upper lip, and obviously they were far more stigmatised than any other area of British society. So in 2007, we got hold of some data from a study called the Adult Psychiatric Morbidity Study. It's a really good study done in England where the data is collected as an interview rather than as a questionnaire. And there's about 3,500 people in that sample. And in that study, we were able to get some questions about, have you ever served in the military? And what we thought we'd find is the people who were ill who were in the military would not be getting help, and everyone else would be a lot better. In fact, we found there was no difference. So these are all the people who happen to have post-traumatic stress disorder, PTSD, and you can see whether you're in the military or not, about 70% aren't getting any help. So whether you're a soldier, whether you're a vet, whether you're a librarian, whatever you might do, the fact is most people who have mental health problems, unfortunately, aren't getting any help at all. So overall, we know that work can be good for your health, and it is for many of us, but it can also be bad. We know that common mental health problems, unsurprisingly, it's all in the name, are pretty common. They affect productivity, and most difficultly, people who are distressed don't seek appropriate help. But of course, we know there are mental health services out there. I can promise you, psychiatrists and psychologists aren't sitting there waiting for people to come in. It's pretty busy. When we ask people about what actually brought you to come and finally seek help, what was the pivot point when you said, okay, enough's enough? The 2 biggest reasons that people report seeking help were that a crisis has happened, got caught drunk driving, told your boss what you think of them, which is obviously not such a good idea, or a significant other, often your spouse, but not always, sometimes your best friend, sometimes your boss, says, if you don't get help, then, and they issue with some ultimatum. So people do get help, but they wait until the very last possible minute, and therein lies the challenge, because by the time they seek the help, it's much more complicated than if they sought it earlier on. Where do people get help from? This is data from deployed troops. Over 60% of people here get help from their friends. That's where they get most of their help from. Only a small amount get help from the doctors or medical people. These are people, military personnel, who have just come back from a deployment. 97% said I spoke to people just like me who've had the similar experiences. Only 8% went to seek to medical and welfare services. People do seek help, but they seek it usually informally from people that they trust and they know. They don't routinely go and seek help from healthcare professionals. And when they do, unfortunately, they do it at the last possible moment. So the question comes, what can an organisation do to try and improve the mental health of their staff without necessarily waiting until they're really ill and then getting them some sort of evidence-based treatment, although that's good news too. So primary prevention is the attempt to try and stop people becoming unwell in the first place. And obviously, if you can do primary prevention, that's clearly the best thing. So the first thing I would say is whatever organisation that you work for, you should really have some sort of policies or guidelines which set out the organisation's responsibilities and attitudes towards mental health. Now, I think that needs to be balanced. For my brother, who's a train driver, it can't say, you should come to work no matter how unwell you are and we'll just support you. Because actually, if he crashes that train, that has some serious consequences. But nor should it say, if you've got a mental health problem, we want you to go away and not come back. It needs to strike an appropriate balance between the responsibilities of the individual and the responsibilities of the employee. Now, we all know, I will say, that policies are very good for gathering dust on a shelf. They're not usually very good for actually making things better unless they're actually acted upon. The next thing that is really important from a preventative point of view is making sure people who are in supervisory positions really know what they're talking about when it comes to this topic. Now, what we found time and time again from military studies and studies done in other organisations is the impact of the supervisor. So this is talking about the person immediately looking after your job, not what the chief executive thinks or the permanent undersecretary or whatever senior person there might be. Their impact is huge. This is data we gathered from in Afghanistan in 2010. We had about 1,500 people in this sample, military personnel who were deployed doing unpleasant duties. And we asked them about their mental health, and we also asked them about their perceptions of their immediate supervisor. And by this, we asked them about, do their leaders embarrass people in front of others? Do they accept extra duties to make themselves look good at the expense of others? Do they treat all the members of the unit fairly, and do they show concern about the safety of their team? Now, overall, just less than 3% of these 1,500 people probably had PTSD, because it was a questionnaire. It's not surprising, they're in a war zone. These are people who said my boss was good. They scored 3 or more, positive ones on here. These are people who said my boss was bad. There's a 10-fold difference in the rates of probable mental ill health in that group. That is a dramatic, dramatic difference. When you look, so that's talking about trauma. This is looking at the general health questionnaire, which is a measure of far more sort of common mental health disorder symptoms. And again, we get the same effect, is that the better the leadership, the lower the rate of mental ill health. So again, the same impact happens. The next thing we know is actually, as well as training being a good technique to try and get people better at doing their job, we should really have training that aims to forge good, mutually supportive teams. And this is a pretty cheesy phrase, I accept, but I think it's really true. There's that in organisations, actually resilience often doesn't lie in individuals, it often lies between individuals. And those social networks that we have with our colleagues and with our supervisors are really what sustains us far more than have I been on a mindfulness course, nothing against mindfulness, or have I done a personal resilience training course. Because actually the evidence is that looking at a team level, how does the team function, how does the team support each other, is actually far more important than what you might necessarily do yourself. And again, we've got data again that the better people felt cohesed, the better they felt joined together, the lower their mental health scores. Now, one thing that's often used in organisations is the idea of screening. So before you can become join the veterinary profession, or before you can become a psychiatrist or a train driver or what have you, is we could give out lots of questionnaires. We could spend some time getting very expensive mental health professionals to come and look you in the eye, a bit like out of Blade Runner, if you've seen that. And the idea is to try and spot the ones who aren't going to make it. Now, this is very seductive. There is what's called the grandmother test. And the grandmother test says that if you've got someone who's about to do a job that they don't want to do, they're doing it for the money, they don't get on with their boss, they've got a sick kid, they're about to go through a marital breakup, your grandmother could tell you that person's going to have problems. You don't need a complicated psychological test. Of course, your grandmother would also tell you that if you go outside in the winter without a jacket on, you'll catch a cold, which is not right, so I understand. And so it's quite hard to work out, when your grandmother's right and wrong. Now, you won't recognise this bloke, I don't think. This is General Marshall, who was Chief of Staff of the US Army at the end of the Second World War. Now, the reason I put him up isn't that I like pictures of old generals. It's the fact is, without meaning to, he did an amazing study on screening. Now, he was an infantry officer. He didn't know anything about psychological health, or at least not directly. But what happened is in 1939, if you wanted to join the US military, you had to see a psychologist or psychiatrist. And they determined if you had true grit or you were made of the right stuff or some cheesy phrase like that. By 1943, they ran out of people. And so General Marshall overturned this policy. And all these people who were deemed to be lacking in grit were allowed to join up. And they found that 80% of them, 80% of them, went on and had a perfectly good war, won medals and acted courageously. Now, we were able to repeat the Marshall study, he didn't call it that, in 2003. So my research team at King's College London, we had gathered data in 2002 on about 3,000 British military personnel. And we didn't know there was going to be a war the next year, but good news for us was there was. And so what we were able to do was to use the data we gathered in 2002 to see whether we could predict who was going to have problems during the war. And so, we knew who we thought was vulnerable. They went to war. We followed them up a year later, and we got it wrong 80% of the time. So it was completely unable to predict. And really importantly, there was a whole bunch of people who we said, oh, they'll be okay, and actually they weren't. So screening is a lovely concept. Can you do pre-roll screening? But it just doesn't work. The other way screening is used is after an incident. So it could be after a suicide, it could be after a traumatic event. And the idea there is to hand out questionnaires or to have healthcare professionals come in and try and talk to you to try and identify whether you've got a problem or not. Now, I can tell you every other nation, apart from the UK, routinely screens their troops who come back from combat zones. So over the last 15 years, there have been probably 2 million Americans, Canadians, Australians, Dutch, all who have been screened, usually twice. The idea is to try and detect whether people have got problems or not, and if they have got problems, the idea is to get them professional help. Now, this is a really nice idea, but no one ever tested it out. The good news is that about 6 or 7 years ago, the US decided that their data they had on their screening program looked slightly dodgy, and they found that people who got screening appeared to do less well than the ones who didn't, which worried them. And so they said, we need to do a randomized control trial. We need to do a proper, decent trial. But they couldn't do it in the US, because to do it, they'd have to stop screening people so they could have a control group, and Congress wouldn't allow them to. So this was really good news for us, because they gave us, who don't do screening, they gave us $3 million, and our government said, yep, not a bad idea. They actually made a decision, which is very unusual these days. We carried out a screening study with 9,000 British troops. And what we did is they came back, half of them got screening, so they got a questionnaire based on the computer, which gave them feedback and said, you're doing okay, or you're not doing so good, or you need to get help. And the other half got the same questionnaires, but got no feedback. And the idea we were looking at was the ones who were screened a year later should have better psychological health. They should have got more help. So 9,000 troops, 3 years, $3 million, and the answer was it made no difference. It didn't make any difference to mental health, and it didn't make any difference to whether they sought more help. We published it in The Lancet, which was a good paper, and as you can imagine, the US were a little bit upset by the result. We're still trying to work that one out. Another thing you can do is in terms of secondary prevention, which is trying to detect people who have got difficulties early on so that you can get them the right sort of care. And inevitably, even with the best management and the best support systems in place, you're still going to have people who will develop difficulties. And what you want to do is overcome this fine question, that people just say I'm fine, and you don't know what they mean. So in the British military, we developed a system called TRIM, which stands for Trauma Risk Management. This was a peer support system that we developed in 1996. We've done 13 academic studies into this now. This is not penicillin for trauma. It doesn't, unfortunately, cure people. But what we know it does is it is very credible. The evidence points towards it helping identify people who've got difficulties and getting them to professional help early on. And we've got data, for instance, showing that troops who were supported using TRIM are 3 times more likely to get help for mental health problems than people who weren't. We also did a TRIM study after the Cumbrian shootings. I don't even remember a guy called Derrick Bird in 2010, who was a taxi driver. For reasons I don't fully understand, he ran amok and shot 30 people, killed 19, including himself. And I won't go into all the odds ratios and things. I know you really want to hear about them, but they are there. But what this study did is look at sickness absence as an outcome. Did the people who got trimmed do better than the people who didn't? And the answer was they did, that they were much less likely to go off long-term sick if you got trim support than if they didn't. Now, this wasn't a randomized control study. This was a comparison study because the people who didn't get trim are not the same. They just didn't get it for some reason. But this was good evidence that actually this makes an operational impact and keeps people going. We also developed a package called STRAW based on that. We just had our first academic publication come out on that in the last week. And this is the same idea, is that you train frontline vets or chefs or train drivers how to sit down and have a structured conversation with a colleague. The idea is to teach them about how to talk to each other, which is sometimes more challenging than you might think. You give them some clues about active listening and do some skills. And what the STRAW practitioner is trying to do is to try and identify risk factors for mental ill health in a colleague. And they do this by having a conversation. So these, if you look at the evidence base for what predicts people having mental health difficulties at work, you'll see in here all the HSC workplace model, the 6 different domains of stress. And we know about sort of poorly adaptive coping, such as people who are drinking too much alcohol, who aren't accessing social support. So by having a structured conversation with someone, the STRAW practitioner looks for those risk factors in their colleagues, and then by identifying how many are present, what they can do is to put them on this continuum. Now, this is not class, it's not diagnosing people, it's just trying to help a non-mental health professional have a structured view about how their colleague is doing. So if someone's healthy, that's good. If someone's yellow, you've often got a few things you can do to try and help them get back to green. If someone's amber, actually, you found someone who's got a lot of stress here. Maybe they're a bit more shouty at home, maybe they're a bit less effective. Or if they're red, actually, they may have a mental health problem and they need to go and see a professional. And I won't go through the whole chart, but the point about STRAW is about enabling a worker, a peer, who we know that people want to speak to have the skills to detect who's got problems and to put in place really simple structures to try and help them get back to fitness. The 2 things we teach in terms of interventions on this, we teach problem-solving therapy, which you'll be aware is pretty simple, but there's a great adage, which is that people in crisis problem solve badly. How many times when you check your pocket for your car keys and they're not there, how many times do you keep checking just in case somehow they come back? And the second thing we teach is also called decisional balance. And what decisional balance is a tool for trying to shift someone towards a positive behavior. So it came out of the drug and alcohol world, but what you can also use it for is shifting people to go and speak to their boss, to take the leave that they should have been taking, to have a conversation with their wife that they've been putting off for a while. All the things that you might think, actually, it could really, really help. And much as you might say, what you need to do is XXX, people don't do it. Decisional balance is a much more useful, motivational way to try and shift people to the right way to get help. And of course, one of the things we also know is that people will tend to listen to their peers quite a lot. And so we can teach, I've mentioned there's a few basic techniques. And unfortunately, where people do become unwell, where they actually develop a mental health problem and they actually need professional help, medication may have a role in some cases. Unfortunately, if we go and see our GPs, often in 7 minutes, the medication is the first and sometimes the only thing that they offer. But as well as having 12 to 16 sessions of cognitive behavioural therapy, there's some really interesting novel ways of delivering help. So King's College London, not my team, another one, ran this one-day, they called it a resilience workshop. In fact, it was CBT for depression that they ran in local libraries down in southeast London, but they thought they wouldn't get people in if they said that, so they got people to come in on the basis of increasing their resilience. And they showed that for mild to moderately depressed people, a one-day package had impact months later. I think that's quite an interesting approach. Remotely delivered therapy, you can do therapy just as effectively by Skype or by instant messaging as you can face-to-face. Not for everybody, but it does work a lot of the time. You can compress therapy. For PTSD, a team, a bit based at King's, but a bit based in Oxford, have come up with a 1-week intervention package. So they deliver 16 hours of trauma-focused cognitive behavioural therapy over 1 week. And the outcomes of that are pretty good. They're doing it at St George's Hospital, the NHS at the moment. Not for everybody, but wouldn't it be great to take someone who was broken and put them through 1 week of intensive therapy and then them to be ready to sort of get back on their road to recovery? And there's also guided self-help. And those of you who sort of interact with IAPT, the Improving Access to Psychological Therapies, will know that actually for basic level, for non-severe disorders, guided self-help is actually a pretty effective way. And there's also some ways you can deliver treatment also in groups, which is an effective way of doing things if you've got lots of people involved. But I come back to the fact is you can deliver as much treatment as you like, but if the difficulties are based at home or based at work, without trying to solve those difficulties, you're wasting your time and your effort. You're much better off putting a social work approach to dealing with things than you are in trying to pay for expensive therapy. And lastly, beware of snake oil salesmen. There are plenty of people out there who will sell you a quick cure. Any of you do NLP, neuro-linguistic programming? Oh, hopefully. So I spent a lot of time dealing with trauma throughout my life, other people's, and a bit of my own as well, but that's another story. In the trauma world, you can go and do a 2-week NLP master practitioner's course. And at the end of that course, you are a life coach, a hypnotherapist, and a trauma therapist. I've obviously wasted years in my life. I should have just gone for the quick 2-week course. But the fact is, there's no evidence that NLP works. And so you've got to be really, really careful. There's a whole lot of, you've probably seen fad diets out there that I don't know if they work or not. But the ones that claim that they treat your depression or the rest of it, they may be great, but no one's done the research. So why would you start with something we don't know works when actually we do know there are some really good approaches out there? So just to end, there's lots of good reasons to proactively support staff. Classic treatment is important, but it's only a very small part of the spaghetti bowl. You've got to look at the rest of it. And really, when it comes to trying to help people stay fit at work, I think having good policies, having trained peers, putting in place cultural changes to make sure that actually the organisation does really care, isn't just ticking the box, and having some treatment processes in place for people who do become unwell, all those things are likely to make a difference. And that's me. Great. Thank you.